So again, good morning and good afternoon and good evening to everybody who's joining us. This is our report to the community where we will discuss the experiences of the aortic dissection community during the COVID-19 pandemic. And I'm happy that everybody's here and thank you for joining us. And certainly if you're watching this at a later time, we're also very happy that you have joined us. Next slide, please. So again, all lines are muted and the chat is going to be open for questions and discussions. There will be polling exercises throughout this talk today, and you will see those polling questions come up when time is due. And then the meeting is recorded and again will be shared on our website. So what we will talk about today is we'll give you the background of the collaborative, the Aortic Dissection Collaborative, and I'll introduce the current stakeholders. Then we will introduce the survey. There was 2 surveys that you have participated in, 1, 2, or both. We'll talk about how we developed the survey. We'll review the results and the qualitative work for you who you've interviewed. That would be the qualitative work part of the deal. And then we'll open it up for next steps and question and answer discussions. Next slide, please. And just as a reminder, our work is funded by PCORI, which is the Patient-Centered Outcomes Research Institute. This was established in 2010 by the Patient Protection and Affordable Care Act. And the goal is to support research that really has direct impact on patient care. And by doing research projects on things called comparative clinical effectiveness research, looking at the current treatments that are being used by physicians and comparing them head to head to see what actually works. Next slide. And so as part of this work, we engaged in this project called Engaging Patients with or at Risk for Aortic Dissections as partners in patient-centered outcomes research. So for PCORI to be able to design studies or fund studies that are focused on patients, we have to have patients being at the front and center, literally from the beginning to the end, from the time of inception of idea of a research question to understanding what's important to patients, and then subsequently the design of the studies. And so we started this endeavor back in August of 2019, and we are now in year number 2. And in red, you can see that we are in the stage where we are working on understanding a patient's research needs. And the goal, again, is to bridge the gap between researchers and patients so that patients are participating in research, not as quote unquote subjects, but really as research partners to where we can get their, your lived experience and understand what is important to you so that we can address those concerns. And that obviously addresses a lot of challenges that are in research, whether it's, having long-term data on outcomes of things that we do and operations that we do or medications that we give, as well as collecting images or dealing with rare diseases. So all these challenges, I think, can be addressed by involving you as front and center in this work that we're doing. So this is our team at the University of Washington. You've met me already. And then also Dr. Peter Byers is my project co-lead. He has been doing this work for a long time in terms of genetics. And then obviously you've met Sarah Lawrence. She was the one who signed you up for this meeting and introduced herself in the beginning. And then Jenny Lee, who's our research scientist, and she's also in charge of the qualitative work that you're going to hear about. She'll be presenting a lot of that today. And then Courtney Segal, who had joined us and also helped us with the data analysis. This is our advisory group: Melanie Case, Navalette Cotter, Jake Howitt, Timo Soderlund, and Deb Trotter. And I see Deb on the screen, and there's quite a few people actually that should be here as well joining us. And they have been really actively involved in the design of the questions that you saw when you applied to the survey and the analysis and interpretation. And then the next slide. And these are a group of stakeholders. So they have also been joining our monthly calls and again, participating with ideas and thoughts of interpretation of the data or where projects can go and represent different backgrounds and bring in different perspectives on the work that we're doing. And then here are the different organizations that have representation as the stakeholder group. So as we continue to grow and engage more people, we're looking forward to having more and more organizations that are involved in the care of people who have aortic dissections, whether as advocacy groups or as industry or research entities. But these groups are all important. So as we continue to work together towards addressing the concerns that people have. So again, the goals of our engagement work is, in the end of the day, the end of the 3 years of this work, we need to identify the key research topics that are important to people and that would be amenable so that we can design trials centered around those questions. And this set of surveys that you have replied to are the beginning of identifying these research topics that are important to people. And again, this is just an example of our stakeholders when they went out and talked to the group of people and explaining why it was important to participate in this work. So just as a reminder, this is the survey that we are discussing today. This was the COVID-19 survey. As you know, it's been over a year now since we've been impacted by the COVID-19 pandemic, and our work with the engagement, with the aortic dissection engagement work, had started prior to COVID-19, and then COVID-19 happened. And so during that time, Victoria became interested in also understanding how this pandemic had impacted people. And so we rolled out simultaneously around the same time that we had the original survey that was still active, we rolled out a second survey in order to understand that impact. So today you'll hear a lot about this particular survey. And then if you click the next slide, and the other survey, which is the original survey, we will be again presenting that to you as a report to the community on April 28th, around the same time as today, and we'll record that as well. So stay tuned, save the date, and stay tuned for that one as well. So what we'll share today are the COVID-19 surveys and interview. We'll go over what we did, what we learned, and what we think it means. And this is where I will transition to Jenny Lee, who will explain all that to you and fill you in.
Great, thanks, Shreen. So I'm really excited to present this to all of you today, to the community. We've been hard at work in the collaborative since summer of last year, working on the survey, getting it out to everybody, learning what the community's experience was like over the course of the first 6 to 8 months of the COVID-19 pandemic, and then also following up on those surveys by inviting folks to do interviews. And so I'm going to talk about the methods that we did, what we actually did, and how we did it. I'm going to tell you what we learned through all of that, through the surveys and through the interviews. And then I'm going to tell you also what we think it means, what the implications we think are of what we've learned from all of you. And then in addition to that, I'm going to ask you all to share with us what you think. So you'll see as we go through that occasionally a little thing will pop up on your screen. It'll be a little poll. You'll be able to tell us how well our findings, what we think we learned, how well does that match up with your own experience or the experience of people you know who have had aortic dissection or are at risk for aortic dissection. So that's what we're going to do here today. And of course, at the end, we're going to save time for discussion and questions. If you have anything to say along the way, feel free to put it in the chat. And I'm looking forward to it. So let's get started. So first of all, here's what we did. Starting in the summer of last year, we sent out surveys that asked about people's experience during the COVID-19 pandemic. That survey ran through the end of September of last year. So we had it open for a few months, I think about 4 months. And over that period of time, 886 people took the survey, which is just fantastic. It was really exciting. So the way that broke down was that 649 people out of that 886 were people who either have had an aortic dissection or are at risk for aortic dissection. 154 of those people were family members or care partners for people who have had or are at risk for dissection. And then we also had 83 physicians answer our survey, which was great. And what I'm going to report to you today, we're really focusing on the people who have had or are at risk for dissection or their family members and care partners. We're not presenting here the information on physicians. So after that, we took the survey responses, and we had a question at the very end of the survey asking that almost 900 people, would you be willing to talk with us more? Can we follow up with you? And can somebody from our team talk with you one-on-one? And over 200 people said, yes, you can contact me, which was just very exciting. It's a super high response rate. So we were really excited about that. And of course, we would have loved to have talked to all 200 and something of you, but what was actually feasible to do was to talk to 23 of you. So I was able to sit virtually over the computer one-on-one with 23 people, 17 folks who were people who've had dissection or are at risk, and then 6 people who are family members or care partners for people with dissection or who are at risk for dissection. And here's what we did with all that information. So as you can see over on the left of the screen, we have our surveys and our interviews. So what we did was we looked at these 2 different data sources separately at first. We took the surveys, we ran them through a bunch of statistical analyses, and we came up with some results around what we learned from the survey. We took the interviews, We combed through the sections of them that talked about COVID-19 specifically. And then we grouped our findings by theme areas. And then we took those two findings, the statistical findings from the surveys and the thematic findings from the interviews, and we looked across the two sets to see what we could learn, what was a pattern that emerged, and how those two sets of findings related to each other. And that's what we have over here on the right hand of the slide, where it says synthesized findings, by which I just mean we took the combined results of those two things and we put them together and we made sense of the results together, which was a big undertaking. It involved myself, it involved Shireen, it involved all of our advisors and stakeholders, everybody on the project team. And in particular, it involved Jake Howitt from our advisory board and Courtney Siegel, who were instrumental in not only coming to that eventual, the conclusions that we're going to share, but also really combed into the interviews with me and helped to make sense of what we learned. So what did we learn? We think we saw out of that data, we think we found three really important takeaways. And those are the things that we're going to share with you today. I'm going to tell you what the takeaways were, why we thought we saw that based on the survey findings and the interview findings, and then what kind of sense we make of that. What do we think the implications are of each of those findings? And as we go through, I'm going to present the findings to you. And then at the end of that, we're going to pause. Sarah's going to pop up a poll on your screen so that you can tell us how well that finding matches with your experience before we move on to the next finding. So we'll pause a little bit after each one as we go through. So takeaway number one. This first takeaway has to do with the question of risk. So what we found is that the aortic dissection community, and I just want to pause and say that when we say the AD community or the aortic dissection community, we mean everybody in the community who has either had a dissection or is at risk for having dissection because they have Marfan syndrome or Loeys-Dietz or family history or something like that. So it includes everybody. But the community lacks clear guidance about whether their aortic health status contributes to COVID-19 risk. That there just isn't clear information that people feel that they can rely on to let them know whether their aortic health impacts their COVID risk, their risk for getting or having poor outcomes from COVID-19. And in that kind of confusing context, folks are adopting protective behaviors, and that's both a risk and an anxiety reduction strategy that people are adopting. So here's what that looked like in the data. One thing we learned about from our survey results was how people were thinking about their own risk. We asked people whether they considered themselves or had been told they were at risk for COVID-19. And when we asked people that question, have you been told or do you think that you are at risk for getting COVID-19, so for contracting COVID-19? About 35% of people who've had dissection and about 22% of people who are at risk for dissection said, yes, I consider myself to be at risk, or I've been told that I'm at risk for contracting the virus. And then when we ask people, do you consider yourself to be at risk for the complications of COVID-19? So in other words, if you got COVID-19, would you be at risk for the poor outcomes, for hospitalization, or for having a very bad case of COVID-19, that sort of thing? And around 60% of people with dissection and about half of people who are at risk for dissection said, yes, I consider myself to be at risk for the complications of COVID-19, or I've been told that I am. So you can see that there isn't, clear consensus in the group. Some people said, yes, I do. Plenty of people said, no, I don't. But then when we asked about protective behaviors, what we found was that people were really kind of across the board adopting the sort of standard set of protective behaviors that are recommended for reducing risk for COVID-19. So we saw a lot of people who said, yes, I wear a mask or a face covering. Yes, I practice social distancing. I monitor my symptoms. I'm avoiding indoor gatherings and outdoor gatherings with friends or family for social purposes. So we did see a high level of compliance or adopting of these behaviors, even in the context of people not fully knowing whether they are at a high risk because of aortic health status. And here's how this played out in the interviews. This is some of the information we learned from people in the interviews. So this is an example of a person who's had an aortic dissection. And what they told us is, I said to myself, if I get this, I don't know how my body will react to it. So I don't feel that it's worth going into work right now and dealing with that. So with that, I lost my health coverage and I had to apply for Medicaid. And then with Medicaid, you pick and choose the cardiologists that are there out of the bunch. But since COVID has happened, I've not been in to see anyone. So this is a person who was in the situation of needing to decide whether they understood their risk level enough and how much risk they could tolerate in their lives for contracting COVID-19, given their aortic health status. And for this person, the answer was, I just don't know how it would affect me. I don't think I can safely go into work right now, and so I'm gonna have to quit my job. And here's another example of a person who is at risk for aortic dissection. This person told us, I feel like they don't even know how at risk I am for COVID based on my aortic health. They're not sure. I remember in the beginning of this whole thing, there was the report that said if you're on losartan or those kind of medicines, you might be less at risk. And then there was another report that says not so much. I feel like nobody knows anything, and that drives me crazy. Somebody should know something, should know already. Is it okay for me to start going out more, or should I keep staying at home like we've been doing? What are the chances that my son will get it if he goes back to school and passes it to me? Is it as severe if I were to get it directly? I don't know. I don't think anybody does. And this quote is really pointing out a sentiment that a lot of people shared, that not only are they unsure, but they've been given different information kind of along the way, that as the picture has changed, the information they're getting has changed, and that leaves them feeling a little bit confused or uncertain about what really the case is in terms of risk. And that this is impacting how people are making decisions, not only for themselves, but also for their families and the level of their ability for, for example, their kids to be going back to school or to be around other children, that sort of thing. And lastly, another quote from a person that we spoke with who is a partner of a person with aortic dissection, who told us, I'm treating it more like he's at risk. And we just didn't know to begin with, are you at risk or not? We don't know. And the general response that we've gotten now that we're almost, and in brackets there's 8 months in, is that he's not at high risk, or likely not at high risk, but we just don't know enough about this to really know that. So I'm more concerned about that, and I'm very conservative in terms of keeping safe and not being around others. And this also is a common sentiment, that because we don't really know, we're playing it very safe. We're being very conservative in what we're doing because we don't really have a real answer. So here's some of what we think this means. First of all, information to date from the CDC on what constitutes a risk condition for getting COVID-19 or for having the poor outcomes associated with COVID-19 don't include any information on rare diseases or conditions. And so we don't know, at least by CDC guidelines, whether aortic dissection or risk for aortic dissection is itself a high-risk condition. We know that cardiac conditions are listed as a high-risk condition, but there's nothing specific about aortic health that CDC is able to tell us. And one of the ramifications of this, one of the things that we think is that when something is known, when there is some sort of evidence, or when we know that there isn't enough evidence, that needs to be communicated better to the community. So really, it isn't just that we need to know the answer, we also need to know more about what is and isn't known. There needs to be just a better line of communication open with the community, and better access to the information that does exist. So are people able to access information from their physicians? Are they finding information that's helpful online, or is that information not particularly helpful? So also the channels of information that people are getting are important to consider. Also, we think that it's really important because, this isn't over yet. We think it's really important to encourage funding agencies to direct money to study the impacts of COVID on people with rare disease, and in particular on the impacts of COVID-19 on folks who are at risk for aortic dissection. We can't know what isn't studied, right? So we think this is really, really important. And as a part of that, we recommend that projects that are ongoing that are specific to aortic disease, that they should incorporate elements around COVID-19 into their data sets, so that we can start to build data sets out that incorporate information about how COVID-19 is impacting the aortic dissection community. And lastly, just, we're at a point right now in the pandemic when vaccination is increasing, and that's all looking really hopeful. We're all really, hoping that we're about to see sort of, a light at the end of this tunnel. But it's really good to temper that with the understanding that this isn't over yet. That COVID-19 has not been vanquished, and that we can just move on from this as an issue. This continues to be an important issue in people's lives and the community's life. And so as we move forward, we need to keep this in mind and keep working on finding these answers for people. So that's takeaway number one. So right now I want to pause, and Sarah's going to pop up a poll. And what we'd really love to know is how well this finding matches with your own experience or with the experience of people you know. Does it match? Yes, it matches. No, it doesn't match, or you're not really sure how well it matches. And you can click that in your browser when it should have popped up, and we'll be able to show you the results. Got about 20 more seconds or so. I'm not sure actually how long, Sarah, you're going to leave the poll open, but when you close it, let us know, and then we can let people know what the result was.
People are slowly but surely voting. We're about 65% of the way. I'll leave it open for a little bit longer.
Great.
Okay, it looks like we're still getting a couple more. Last chance. I'm going to close it in the next 10 seconds or so. Okay. So now share results.
Great. So it looks like, according to this group, about 75% of you feel like that matches your own experience or the experience of people you know in the community. And so that's a really important finding for us. I see also that a couple of folks felt like it didn't match your experience, and also a few more folks felt like you weren't quite sure. If there's anything that you want to tell us about that, either way, whether you said it matches or it doesn't, if you want to put that into the chat, then we'll be saving the chat, and we can talk through that at the end of the presentation, or we'll also save it for our own records. One of the things that we plan to do, by the way, with these questions we're asking is that this is going to help us inform our final analysis. And we plan to publish our results, and that will help us, finalize those findings for publication. So it's really important to us to know from the community, from all of you, your thoughts on what we think we've seen. All right, so I'm going to move on. Sarah, do I need to close out that poll, or can you do it?
I closed the poll. Are you still seeing it?
I'm still seeing it, but that's probably just on my end. I'll just close it.
I'm seeing it too. Is anybody else seeing it? Okay, so it must be just us.
Yeah, I think because we're co-hosts. Okay, all right, so we will move on. So here is finding number 2, takeaway number 2. So in this finding, what we saw was that the COVID-19 pandemic has really increased how hard it is, the complexity and the burden of navigating an already very complex healthcare environment for people who are in the community. So in other words, it was already, people were already experiencing a lot of work to maintain their care, that like navigating through getting to the right doctor and getting the right appointments and talking to the people you need to talk to, getting health insurance coverage, getting all of those pieces in place was already very complex. That's already a high level of work that people are doing to maintain care access, to get the health care that you need. And then COVID-19 came in and made that situation even more complex. And so now you have added on top of the layer of regular complexity, you have this other layer of, oh, now we have COVID-19 to contend with as well. And that is making it just a little, or in some cases, a lot more difficult to maintain the healthcare that you need to keep yourself well. So here's what we saw in the survey results that helped point to this. So one of the things we asked people about, you will remember if you took our survey, is that we wanted to know how was the pandemic impacting your ability to actually just physically get into the clinic for your appointments. So we wanted to know, have you had any appointments canceled or rescheduled since the start of the pandemic in March? And we had 249 people, so that's about 40%, almost half of people who said they had had at least one appointment for regular scheduled care canceled or rescheduled. We also asked people about access to emergency care because we had been hearing around in the community that, especially at the beginning of the pandemic, that maybe people were reluctant to go into emergency care, and that there was concern that people weren't getting the care they needed. And so we asked all of you, and here's what we heard. So of everybody who answered, 80 people had said that at some point during the pandemic, those first, from March until they answered their survey, they had experienced some type of aortic health related symptom that they thought needed emergency care. So some kind of symptom that they thought, I should go to the ER or to the urgent care for this. And of those, 67% did go. So about 2/3 of people said, yes, I had symptoms and I went in and I got care. And about 1/3 of people said they chose not to go. So they had the symptom and they said, you know what, I'm not going to go in. And the most common reason that people told us that was the case for was because they were worried about getting COVID-19 from being in the emergency room. Now, we also learned that of those folks, so that was 26 people, or about 1 in 3, who told us that they didn't go even though they had symptoms. Only one person reported that there was any kind of negative effect from that. And that person reported having continued heart pains. So we're happy that at least in our group, we didn't have anybody who had, dire consequences of not having gotten emergency care, but we did see that people were, at least some people were choosing not to go in for ER related care. And then we asked the whole group of respondents, everybody who took the survey, okay, so maybe you haven't had clinic appointments canceled, maybe you have, maybe you haven't, but how do you feel about your ability to get in if you should need to? So are you worried that you'll have any difficulty accessing or difficulty going in for your ongoing care or just your regular monitoring or your ability to get your needed medications? And about 1/3 of people said, yes, I'm worried about that. We asked that same question about access to surgery. If you needed surgery, are you worried that you wouldn't be able to get it? And about 20% of people, or 1 in 5, said, yeah, I'm worried I wouldn't be able to get it. And for emergency care, we saw about 1 in 3, again, a little over 1 in 3 people saying, yeah, I'm worried that I wouldn't be able to get the emergency care I needed if I needed to go in because of the pandemic. So this is clearly something that's really on people's minds. And here's what we learned. So what we learned through the interviews is that COVID-19 is really impacting people's access to care, but it's more than just, can I get into the clinic or can I not get into the clinic? And here are some of the ways that we heard about that. So this is a person who's had an aortic dissection, and they're describing to me a situation where over the summer they had some imaging scheduled, and then here's what happened with that. So she was this person was talking to the nurse who said, and then she said, you're due for your next MRI in August, so let's get that scheduled. So we got that scheduled and I went for my appointment and they said, oh, well, our policy is that you have to have chest clearance before we'll do an MRI on you, even though you've had multiple MRIs because you've had heart surgery. So I didn't get to do my test that day. And then it was this whole fiasco of getting clearance and all of this. I had to have a CT scan because I didn't pass the X-ray because there's too much interference. So finally, I had the neck MRI done last Saturday, and next Wednesday, I have the chest MRI. And this was in the fall that I was talking to this person. All of these interviews took place in October. So that was a long time span between August, when it had been originally scheduled, and then October, when this person is finally able to get in. And they concluded by saying, it definitely was messed up, which just increases my anxiety. I keep reminding myself, if my dissection is extended, it's okay. We're doing what they would do to medically manage it anyway. So this is a case where the person had some delay in care and they were eventually able to get in, but they had to go through a lot to get there. And you can imagine that something like this might occur during normal circumstances. But then when you think of the situation in the context of COVID and that extra level of worry, this is just a harder situation all around. And the result was that this person was left feeling anxious because they rely on their regular monitoring to reassure them, okay, I've been monitored, everything looks okay, I'm good for another 6 months until my next monitoring. And so the delay in being able to have that really impacted this person. And here's an example of a person who's at risk for aortic dissection who talked to us about an experience of going into the ER. So this was really interesting. This person said, I did go to the ER because I was having a really bad headache and my blood pressure was high. And that made me think that maybe I'm having this vertebral artery dissection again. And I went to the ER, I sat in the waiting room for about 3 hours and nobody ever came and got me. And I ended up going home. And I think at this time, the pandemic wasn't at its worst, but still you're thinking, I don't really want to walk into an ER if I don't absolutely have to. And I couldn't have somebody there with me. That was the other thing. So if I got admitted, I was going to be there by myself. So all of those things were just added on to the usual thought process of, do I really want to waste my time with going to the ER if it's going to be absolutely nothing? It's one more thing to think about when you're considering whether or not to go to the ER. So again, that just added layer of complexity. It's already on your mind. Am I going to waste my time going to the ER? Is this symptom really nothing? Kind of, I think a lot of people can relate to that feeling of not really being sure if this symptom is something that warrants going to the ER. And then added onto that, knowing that if you go into the ER, you have these additional barriers that are around COVID, worry about contracting COVID or not being able to bring a loved one with you, that sort of thing. And lastly, I want to point out that actually we talked to some folks who said they didn't have any disruptions in their care at all related to the pandemic. And this is an example of a person who said that their spouse who has aortic dissection didn't have any disruption. So this person said, no, she didn't, because the scheduling for her scan worked out such that by the time she needed her annual scan, they were back open for business. So it didn't impact her. And this is pretty typical of when we heard from people that there wasn't a disruption in care. It was often a matter of timing, essentially, that someone who has scans every 6 months or every 12 months fell kind of into a window where when there were some pretty big disruptions in care at the beginning of the pandemic, they didn't have anything scheduled anyway. They didn't have anything came up they needed to see anyone for, and so it didn't really impact them. Okay, so here are some things that we are taking away from this, some of what we think this means. First of all, that there is a real need for maintaining communications and relationships with care providers, even when these delays are happening. We heard from people who understood that the delays were necessary, that they were even, good because we didn't want to be bringing a lot of people into clinic while COVID was really circulating in communities, and we were lowering everyone's risk by doing that. But on the other hand, there's this need that people have to maintain, if not actual care, then at least care relationships with their providers, where the lines of communication are still open, where they still feel that they can access their care provider should they need it. And not only that, but that there's a real need to be mindful of the psychological impact. So even if there's a situation where a provider is looking at a patient's chart and thinking, oh, this patient is doing great, they've been doing great for a long time, we can put off imaging, for another 2 months and they're going to be okay, that putting off for another 2 months may have a large psychological impact, really increase someone's anxiety on the patient's end of things. And so there's a need to acknowledge that, and that there's, potentially ways that we can prioritize or recommend that people prioritize how to deal with that around maintaining contact, especially with people who on the provider's end you feel may be more kind of susceptible to worry or anxiety, that those are people that you definitely want to be reaching out to if you can as the provider to maintain those relationships. And also that going forward, there's a real need to figure out, how to provide kind of safety nets for folks to ensure that continuity of care. This transition happened so quickly. It was very abrupt. There wasn't the time or ability really to plan for how to build these safety nets, how to make sure that people could be contacted regularly, how to maintain care even when it had to happen outside the clinic. And it all ramped up very quickly and was great. But now that we've done that, there are some lessons I think that we can apply moving forward to how to make sure that those safety nets are in place should, more disruptions to care occur in the future. All right, so we're going to pause again. We're going to ask everyone to weigh in. So how well does this second finding reflect your experience? Great. Looks like we've got a little over, now we're at about 2/3 of folks. Great. Give it another little bit and see if more folks want to chime in.
Okay, it hasn't moved in a few seconds, so I'll go ahead and close it.
All right. So it looks again like about roughly the same breakdown. In this case, almost 80% of folks who answered feel like it matches your own experience pretty well. Again, I would encourage you to, if there's anything in addition to that that you want to let us know about, please put it in the chat. But yeah, thank you. It's great feedback for us. Okay, so I'm going to move onward to our third and final takeaway. So this, I think, is not going to come as a big surprise to anyone in the community, but telehealth during the pandemic has really been a critical component of how the community is navigating this really complicated access to care. But not all telehealth is preferred or effective care, really. So it's not just all roses around telehealth. It's been a huge boon, but also there are some potential things to think about telehealth. So here's what we saw from the survey results. And what we did was we asked everybody who took the survey during, since March, since the start of the pandemic, have you had any telehealth appointments? And we had about 25% of people who said, yep, I've had a telehealth appointment. And so we asked those people, that 25%, we asked them how they had felt. We gave them a set of questions that asked them their level of satisfaction, their opinion of their experience with using telehealth. So here's the good stuff. Here's the 5 stars. So 75%, about 75% of people agreed with the statement, I felt comfortable with my telehealth visit. That's great news. And then round about that, actually closer to 80% of people said, overall, I am satisfied with my telehealth visits. Also great. And then about half of people felt that telehealth was easier for them than seeing the provider in person. These are all signs that the telehealth that people were receiving was really working for them and that was all going pretty well. On the other hand, we had some results that kind of didn't contradict that, but just showed a little bit more of a nuanced picture. And one finding was that people, about 70% or so of people said they agreed with the statement, I would rather see my provider in person. So maybe telehealth was okay for them, but they'd prefer to see their provider in person. And this one, the statement was, I have better healthcare results by having a telehealth visit. Only 12% of people agreed with that statement. And what we saw was that close to half of people were neutral on that statement. We asked people agree, neutral, disagree, basically. And 40-ish% of people disagreed. They felt they did not have better healthcare as a result of their telehealth visit. So this is a little bit of a nuanced picture. And the interviews really helped us kind of to figure out what those dynamics really were. And what we learned is that telehealth is really, really useful in some very specific ways. And then there are some contexts where it doesn't work quite as well. So here's an example from a parent of a child who's at risk for aortic dissection. And they told us it's kind of tough with the traveling. So the telehealth appointments this year were kind of a little bit of a reprieve from some of the traveling. I think a lot of us really do appreciate the telehealth appointments if they were every other year in person, because obviously there are things you would want to see the doctor in person for. I know Dr. X does an ultrasound on all of her patients, so it's kind of hard to do that over the phone. And telehealth appointments are really super helpful, even if it's a local doctor. When you have a kid who has all of these doctors and all of these emergency room visits and physical therapy and psychiatry and just so many appointments that you're just overwhelmed. And you have to go pick them up from school and you have to take time off of work. Doing telehealth appointments in general, it helps as far as balancing work and caring for your child. I think that COVID pushed the healthcare system into doing it, and I hope that it sticks around a bit. So this is a great illustration of how telehealth has been a real benefit for folks in the community. So one thing is that many of you know is that in order to access specialist care, a lot of people are having to travel long distances. So the travel that this parent is referring to is traveling to take their child out of state to see a specialist in their child's condition, and that can be a real big burden. And in addition, that there is the need to, even on the local level, navigate lots of different care providers and different appointments, and that is really challenging. And being able to do some of that by telehealth has really made it a lot easier for this family. But they also note that it's not great for everything. There are times when people really want to see their provider in person, and some of that stuff has to do with imaging. In this community, there's a lot of imaging that people are having on an annual or, twice a year, or even more kind of basis. And those are the types of appointments where people, first of all, you have to go in person to have the imaging, but you may want to follow up in person potentially with your doctor as well on those things. And here's another example of kind of that context of when maybe telehealth doesn't work so well for folks. So this is the spouse of a person who's had an aortic dissection. And they said, we had a series of telemedicine consultations this summer during the pandemic after the dissection to talk about his current condition. And they were convenient, but it didn't seem like it moved the ball forward as much. It seemed harder to have the real conversation about, are you going to do this surgery or not? We went in person to make that decision. So it was good, but I felt that telemedicine also had its limitations. So when you're really, you're negotiating, for yourself, your own healthcare, what is the right course of action for you? Are you going to have a surgery? Are you not going to have a surgery? Those sorts of things may be best suited to in-person consultations potentially, where people feel like they can really get into the meat of their questions and really talk to their provider. Seems like maybe some people at least feel like that's a little more challenging over a telehealth kind of platform. So here's what we think this means. First of all, the expansion of telehealth at the beginning of the pandemic was pandemic specific. So all the policy that went into place that allowed this to happen is meant to eventually end when the COVID-19 pandemic is over. So we think it's important to think about telehealth and what it means in this community, not just during the pandemic, but going forward. So one thing that's really important to note is that telehealth reduces some significant barriers to care in this community. So it reduces geographic barriers. If you can get on a video call or a telephone with a provider who's 3 states away, that is an enormous barrier reduction for you. It's also an economic barrier reduction because some people in the community have the economic means to travel and be able to see providers out of state in order to get the best possible care. But many, many people in the community don't have the ability to do that because it's very expensive to do so. And it may not be covered by insurance, et cetera, et cetera. So reducing that, putting it in place that if there's an out-of-state expert that now your insurance covers and now you can see, because you can see them remotely via telehealth, that's a major benefit to the community. And also it decreases time-related barriers to care. So if you're having to negotiate even on the local level, like that parent explained, lots of different doctor appointments and different care providers, you're really able to reduce the amount of work it takes to maintain your health or maintain your loved one's health by having at least some of that happen through telehealth. So we think that there should be an exception for accessing telehealth care for rare diseases, and in particular for the AD community, even if that coverage isn't continued beyond the COVID-19 pandemic. So if that policy all goes back to how it was before, where telehealth isn't openly available to everyone for all conditions, we think that there should be an exception made for people in this community and in probably other rare disease communities as well, to be able to access the care that's really vital, that really can't happen in the same way without access to telehealth. We also think we probably recommend a hybrid kind of approach based on a particular person's needs and context. So for example, some people told us that I really want to be able to see my provider for an initial visit, especially if I'm establishing care with a new provider, I want to be able to see them in person. But then afterward, maybe I would want to follow up by telehealth appointment. So that kind of thing, just based on a person's own needs and context, that it can be negotiated about what's in person, what's done remotely. And also we want to note that care isn't all clinical, it's relational too. It's really important to build trust and build relationships with care providers, between care providers and patients. And some of what we heard from folks is that it feels in some instances easier to build those relationships in person. And so we want to be thoughtful about how we do telehealth and make sure that it's not replacing entirely in-person visits, but also that we think about how we use telehealth in ways that can still help facilitate those relationships and the building of trust. Like, for example, maybe using video rather than phone call, having to be distance, but face-to-face on a video can be one way to help maintain that trust or to build that trust. And then also we want to acknowledge there are some real logistical challenges to this, especially on the provider's end. before the pandemic, the situation was that if you were a licensed provider, say in Colorado, you couldn't practice, you couldn't see people who lived in California, for example. You couldn't see out-of-state patients unless you held a medical license in that state also. So it's changed because of the new policy around telehealth, but those logistical challenges still exist, and there will need to be thought put into how that's negotiated at a policy level going forward. So provider licensure and also billing across state lines, those kinds of things need to be figured out for this to really work long-term. Okay, that's it. That's the third takeaway. And so I'll pause, and we're gonna put up another poll for you to ask you again for the third time, how well does this reflect your own experience? Maybe we'll give it just another 10 seconds or so. So anybody else who hasn't had a chance to answer can do that if you'd like to.
Okay, I'm gonna end.
Okay, great. So still about 75% of people, this says 74%, who feel that this finding matches with your own experience. And one who says maybe not, and then a few who say, I'm not really sure. So about 5 people who said, I'm not really sure whether it does or not. And again, we'd love to hear your thoughts if there's anything else you'd like to let us know about that in the chat. Great. Well, thank you all very much. That is it in terms of my reporting to you. And now I think we're going to have some time for discussion and questions. And I'm going to hand the metaphorical mic back over to Shireen to let you lead us through that.
Thank you, Jenny. And I do want to give a virtual round of applause for Jenny and the team that worked on this. I mean, they spent a lot of hours, she and Jake and Courtney, so to bring this together. So thank you. We can stop the slide sharing, and then that way we can all see everybody. If you have a camera, we'd love it if you can turn on your camera so we can see your smiling face. And then we can do with hand raising, and we can call on people as we go through so that everybody gets an opportunity to speak. And that's about it. That's all I have in terms of organization. I thought I saw a hand from Chris Underwood.
Sorry, I had to get unmuted. I wasn't really trying to ask a question. I was trying to applaud.
Oh, we appreciate that. Thank you. Well, the floor, thank you. That's beautiful. So, I mean, the virtual floor is open for questions, for discussion, comments, things you like, things you thought resonated or didn't. This is really open time for that.
I have a question, Shireen.
Yes, ma'am.
It's Eileen from the Mark Fan Foundation. How are you? This was great. Really great information. I just have a question about the breakdown of the survey respondents in terms of male, female, and diversity. Was it a mix of races? Because that's something that we're trying to get at also.
Jenny, do you have that on hand?
Yeah, I don't have that on hand, but I can pull it up. I can tell you that the survey responses followed what's fairly typical of a lot of research, which is that folks who are, a race other than white Caucasian are less well represented. That's a problem in research generally. And one of the things we did, because we expected that that was likely to happen, we really wanted to make sure that we represented the community very well. And we wanted to make sure that we talked to people who represented the diversity of the community that's actually out there. Both in terms of race, ethnicity, but also in terms of geographical distribution and in terms of gender, that sort of thing. So we did what we would call oversampling. of different community members based on what they told us their race and ethnicity was and what they told us about the region they lived in, to make sure that we talked to people who had a variety of experiences and backgrounds. So the interviews represent the community really well. The surveys, I can find the actual numbers, but they are not, they probably don't fall out quite as well along those lines in terms of demographic representation in that way.
One thing that is interesting in this survey and the earlier survey is that we had over half were women who responded, and less than half were men. Normally, when we think of aortic dissections, or at least if you read the textbook, we say that it's 70% men, 30% women. So I would say women were probably overrepresented, but that was really exciting to see. And it also reflects comfort with social media and who's active on social media, right? That's how we were able to reach a lot of people. The people that are in this group probably heard about this through social media. So we're missing access, or we're not reaching people who are not on social media, which is something, we would like to fix, and at least make sure that we really have representation from everybody. Deanna, I think you were next.
Well, what I wanted to know was your number of respondents to U.S. as compared to Canada, because in Canada we have a completely different healthcare system than what you do, and even provincially to provincially, it varies. And so I wanted to know also what representation of, for example, somebody with Ehlers-Danlos vascular type as opposed to the number of people that have aortal dissections through other, I guess, health anomalies.
Yeah, so I can tell you that, so we broke our sample down into US residents and non-US residents. So we did ask country, and we have that data, but it was a small number from non-US countries, although Canada was one of the larger groups. I don't remember the actual number just off the top of my head. But so we had 532 people who lived in the US and 197 who lived outside the US. And then we had 150-ish who didn't answer that question. That was, the demographics questions were all the way at the end of the survey, and not everyone made it quite all the way through. So we had a fair group of people who didn't make it that far and didn't tell us where they were from. But it's a great point that, especially when you're thinking of how people navigate a healthcare system in a very different context, like in Canada or like the UK, that's going to look pretty different. People's experiences might be pretty different. I'll also say that the interview participants were all drawn from the US. So we talked to folks specifically in the US for the interviews.
And I'm pulling in the numbers here. You can see like what our data looks like on a day-to-day for the boring part of the job, if you will. But to answer your question, there were 61 people from Canada who responded to the COVID survey, 529 in the United States. Now, when we go in and remove the duplicates, because there's some duplicates, the numbers will change, but this is the first pass. So you can see that, 60% were in the United States, 22% were outside the United States, and 17% did not make it to the end of that survey to answer that question. And then going back to, you also asked about, here's the gender. You can see that women, were overrepresented, so 58% versus 41% men. And then in terms of Marfan syndrome, we had, and this is people who were told they have risk conditions. So this is not the people who've had dissections. This is only in the population that were at risk. We asked them, what was the risk factor? So you can see that about 60% of them had Marfan syndrome, 12% had vascular EDS, and 14% had Loeys Dietz.
Thank you.
You're welcome. Linda, you have your hand up.
Yeah, a couple of things. I'm blessed to be living in Denver, where we have a very robust healthcare system out here. And my initial dissection was 10 years ago. And then my second repair was 8 years ago. Back then we didn't, at first it took them like, probably almost 24 hours to diagnose me. I don't know if I have a type A or a type B. I don't remember that terminology being used at all. And one of the things that concerns me is that I'm a survivor. My older brother dissected a few years ago and he did not survive, and he ended up having Marfan's, which they told us after the autopsy. But and now my brother and sister are having difficulty getting tested because depending on where you are and who your healthcare provider is, they don't necessarily see AD as a risk, not just for COVID, but for anything. So kind of off topic a little bit, but as far as COVID goes, I mean, I treat myself like I'm at risk, but I'm also around a lot of people that have compromised immune systems. And so for me, I follow all of the guidelines because God forbid I were to pass it on to anybody else and kill them. That's more my fear than worrying about me. I've got other health conditions that could make it difficult for me, but I don't think the aortic dissection is one that they're considering a risk for me out here.
I appreciate you sharing that. And Linda, it's very interesting because I was having this conversation today with somebody else about the genetic testing. 10 years ago, people didn't really think about genetic testing as much. That is changing. And it is easier now to get genetic testing than it was 10 years ago, or even 5 years ago for that matter.
Okay.
So, particularly in your circumstance, because you have a family history, that is a strong reason actually to get tested. And most insurance companies will not reject that. They will actually, agree to that, particularly if you have, your brother's diagnosis. So just something to think about, to be empowered when you have that discussion with your team.
Okay, I'm not worried about it for me because I already know what my risk is, but my brother's been trying to get tested since my older brother died.
Same deal.
Yeah, and my sister's been trying to get tested, so I'll tell him to keep pushing. Thank you.
You're welcome. Any other comments from anyone in the group? So one of the things we're doing with this data, of course, is like Jenny explained, we have these themes that we will discuss. And so from an academic perspective, the currency of academia is through publications, and then that's how we can quote unquote disseminate the information to people who read these journals, right, or try to reach policy people. And we're specifically targeting a policy audience for this data because that's part of what we wanted to change how people think about aortic dissection, or at least try to understand the implications of telemedicine, for example, and how we can use that to help provide better care to people who are affected. And to Deborah's point earlier, when she said aortic dissection was not on the list of risk factors, where somebody mentioned that somewhere in Canada, this was actually listed. So it just shows you how there's variation in care. So this is an opportunity to point that out in the work that we are doing. But the other part of it is we want to get this data to the community as well, because people on a day-to-day are not going to pick up the Journal of Health Policy and read this article. And so hopefully they're watching this video or later on joining at their own time. But we want to get this information out to the community as well, because they participated, and I'm sure they would want to hear about what they added. So I'd love your help in terms of how do we reach more people with aortic dissections, particularly people who are not active on social media. So that was one thing that I wanted to bring to the community with a question, or as a question.
Shireen?
Yes, ma'am.
So, I mean, being involved in public relations for so many years and being slave to publication embargoes, like what and how do you want us to share it? Because from the Market Foundation, we have a variety of vehicles. Some are social media and some are in other ways. So, what are we allowed to do? You want us to just get it all out there? Is there something that you've written that is like a layperson summary that you want us to get out there? Like, tell us what we can do and we will do what we can. I mean, it's great information.
Well, we can share this particular, recording so people can watch that as well. And we will have a compendium or an accompanying polling with those 3 questions that we had asked, because we really want to hear from other people. But I also like the idea of the 1-page summary. I think that's a great idea. Don't you think, Jenny and Sarah? And I see head shaking, for people who are busy and maybe don't want to spend an hour listening to this, but can just look quickly at the highlights. So we can share that with the community. And I think I saw Deanna's hand up too.
Yeah, what I was thinking is that, 1-page summary is great, and if that could be accessible in let's say doctor's offices or specialist offices where somebody who's just been diagnosed, they'll be able to pick it up and read it. We all know that when a doctor is talking to us, it's information overload. And if this is something that you're just being introduced to, you have all this stuff that the doctor's talking, but something tangible in your hands that you can read and go back to and look at is something I think that would be useful, especially for, you know, people, pardon me, but, you know, our older generation who don't go onto the computer or don't even use a cell phone and have no information. I think something that, like Eileen said, something in your hands that you can, a one-page summary they can read, that know that they're not alone.
No, I agree. And just to sort of, again, to update everybody, this Monday, we presented the other survey data to the stakeholder group. That's the data that we'll present to the community on the 27th. And one of we are honing in on what are the topics for research that need to be attended to and dividing people into groups. So one of the groups that was nominated was basically education, right? How do we get good educational materials, not only in the hands of patients, but also in the hands of busy physicians who may not see a lot of aortic dissection, but are family physicians who take care of people with aortic dissections. So that resonates very well with what you just said.
I have to go. I want to say thank you to everybody for this. This was absolutely wonderful. And please, if that's the reason I have to go, you need to go. So please keep me in the loop with everything, okay? I appreciate it. Thank you.
You're welcome. Have a good evening. There's a comment here from Patrick. Patrick, do you want to speak, or do you want me to read your comment?
It looks like he had to go.
Okay. Well, here's what Patrick was saying, is that I really love the patient and not sure, I think this must be a typo, input in the conversation. He said the collaborative will be really helpful to increase awareness and help disseminate best practices and better care. This is a great initiative, should be replicated in other areas of vascular surgery, aortic aneurysms and so on. So that was good comments there. All right, well, we're really wrapping up, but this is last chance. Anybody who wants to add information, or if not, please send us, by email as well, your thoughts afterwards as you reflect on this. We really want your input.
Thank you, Sheree.
You're welcome. All right, well, thank you everybody for spending the evening with us. I really appreciate your time.
Thank you so much.
Thank you, everybody.
Bye-bye.
Thank you so much for the
Thank you.
time. Very educational.
Thank you.